Hey, this is John Schonert, and we're going to talk about capnography and cardiac arrest. So I always like to start lectures off with a case. So you're working a shift and EMS brings in a 60-year-old male, fall at home, cardiac arrest. CPR has been ongoing for about 10 minutes now. He's been shocked a couple times now, is in PEA. They bring him in actively doing chest compressions, already intubated, and they have this sensor hooked up to his endotracheal tube. They say his end-tidal CO2 is 36, and like most ED docs that I've talked to, they either say, "Capno what?" or "that's useless here," and then they just essentially kind of push it off and no longer use it during the code. So I'm here to at least try to convince you otherwise, or at least try to think about using this during cardiac arrest. So what is capnography? To break it down in its simplest form, capnography equals the measurement of CO2 that has expired from the patient. It uses an IR beam which can measure the concentration of a specific molecule, i.e. CO2, in the air continuously. So when we're looking at lung physiology, right before you start to exhale, the air in your lungs doesn't all have the same concentration of CO2. The highest concentration is actually in the alveoli, where gas exchange was done. And as you move more proximally up the bronchial tree, you essentially get to anatomical dead space, kind of in the bronchial mainstem, where CO2 concentration is essentially zero. So on a capnography waveform, it makes sense when you first start to exhale, you're only exhaling dead space, which has a concentration of CO2 of zero. As you're exhaling more, the concentration of CO2 increases to the point where it hits a plateau, and this is essentially where it's the alveolar concentration, or the highest amount of CO2. Basically, right before you inhale, you hit this point called the end-tidal CO2, and that's kind of the number we care about in cardiac arrest. So we all can agree that capnography can work very well in monitoring the ventilatory status of a patient, particularly in conscious sedation. On the end-tidal CO2 waveform, when a patient becomes apneic or starts to hypoventilate from too much sedation, you'll be able to pick it up a lot quicker compared to just vitals and pulse ox. And so this is perfect for complex forearm fractures or a hip dislocation or an MRI, basically any patient that requires some sort of sedation. That's not what I'm trying to convince you about today. So in a patient that is intubated and getting assisted ventilation during cardiac arrest, what's the point? You don't have to worry about hypoventilation or apnea in a patient that EMS or respiratory therapist is already ventilating appropriately. So let's think about the monitoring in cardiac arrest. So when you get return of spontaneous circulation, what is it? It happens when you check for a pulse and they have one again. So what does that mean? It means the patient's heart started working again and that their cardiac output suddenly has increased. So when you pronounce patient, what have you decided and seen? You essentially have seen that the patient has not had a pulse or any sort of meaningful cardiac output for a long period of time, and that there's essentially no chance of any sort of life or quality of life if you were to continue resuscitation. So you still following me? What I'm getting at is that a cardiac arrest outcome is really determined by what happens to the patient's cardiac output, whether that be something we did or something that the patient's heart did spontaneously. So looking back at the CO2 level, what is it dependent on? If you remember back to basic physiology, it's dependent on the lungs' ventilation and perfusion, or the pulmonary perfusion pressure. So if the ventilation is set constant with good inspiration-expiration done by an intubated patient by a respiratory therapist, then what is CO2 dependent on in a cardiac arrest? The pulmonary perfusion pressure or the patient's cardiac output. So if the pulmonary perfusion from cardiac output is low or minimal, the CO2 will be low or minimal. If it is elevated, the CO2 will rise as well. Alright, so this is the key to it all. In a cardiac arrest patient that's intubated, the end-tidal CO2 equals the cardiac output. So with CPR, you're pushing in the heart to cause artificial circulation and hopefully get a somewhat decent cardiac output to continue to perfuse the brain and heart of the patient. So in a cardiac arrest scene, say one of the team members is doing compressions for a while, and you start noticing that CO2 is dropping. What's happening? The CO2 is dropping likely because the cardiac output is decreasing as well due to the poor compressions. So the team member is probably fatigued and you need to likely switch him out. So what if you're doing great CPR and at the 10-minute mark you all of a sudden see an abrupt increase in the CO2 on the monitor? What just happened? A person doesn't magically get their pulse back as soon as you check it during a pulse check. They likely had a return of spontaneous circulations during your compressions, and then you finally noticed it whenever you did a pulse check. In this case, the likely increase in CO2 likely represents return of spontaneous circulation. This doesn't mean you need to check every time there's a sudden increase in CO2, but just anticipate that during your next pulse check that you likely will have one. So say you're doing CPR and you hit the 20-minute mark of ACLS and nothing has changed. The patient has been in PEA, in and out of another rhythm, the whole time with no pulse. Typically you think about calling the code. It just means you would weigh on the scenario, maybe look at the patient and decide yes or no if you would call it or to continue. So what if I told you that end-tidal CO2 can be another feather in your cap for deciding whether or not the patient really has any chance or not of getting return of spontaneous circulations with continuing? This is where I think end-tidal CO2 in cardiac arrest has the most bang for its buck. Multiple papers and researchers have shown that after 20 minutes, a CO2 level typically around 20 or better has a better chance of ROSC, whereas a level below 10 essentially has none. So I wish I could talk about these papers a little bit more, but basically they both looked at cardiac arrest patients and showed that in the Levine paper on the left, none of the 39 of the 150 patients survived had a CO2 under 10, whereas the Kolar paper showed that if it was under 15, none of them survived. But it actually showed that ROSC was majority of the time in patients that were around 30. So nothing's perfect and everything has its limitations. A recent paper at a resuscitation did show the benefits of CO2 in cardiac arrest, though it did show many variables that can counter and cause variations in the CO2, including respiratory causes of the arrest, pulmonary embolism, and the various different rhythms. So here's a prime example of how capnography worked well. This guy is Howard Snitzer. He had a cardiac arrest several years ago, and even though he never had ROSC after multiple meds and shocks, his end-tidal II still remained high, and so the team felt like they needed to continue and actually resuscitate him for 96 minutes straight before he finally got ROSC. And so this is a very good case of how capnography worked well. He's still neurally intact and able to walk and talk today. So are you convinced yet? Here's a summary slide. Uses for capnography and cardiac arrest: for swapping the chest compressor, for detection of ROSC, and for verification of decision to continue after 20 minutes. Thanks. Any questions, comments, email me, Twitter me. Here are my references.